Right, I would like to thank our addressing the key challenges insulin therapy. The challenge for physicians whenever we start insulin therapy, this patient will go to another doctor. Will lose suggest challenge for us. So these are the eight key challenges. So hypoglycemia is the most common issue with insulin therapy because insulin is very potent anti-diabetic drug because of which the commonest hypoglycemia occurs during insulin with the competitive, because of which lot of patients have poor compliance, and that can lead to many times overeating. Get hypoglycemia, to prevent that they will start overeating. And how to address this hypoglycemia? One is uh, precautions is very important. Whenever you start insulin to the patient, you have to spend good amount of time in educating them about the insulin. And either you do it or any competent person in your clinic or hospital has to do. And precautions should be explained, like what are the symptoms, warning symptoms of corrections, proper way of corrections. When they get hypoglycemia, they start eating some food, chapati or something. Advise them they should be taking the fast acting carbohydrate, glucose, sugar, peppermint, or the beverages like and many times the amount of correction. What happens is they instead of taking 25 gram of fast acting glucose carbs, is almost 5 spoon of sugar or 5 glucose powder. They take only 1 spoon of sugar and they will expect that it will get correct. And they're very worried about of the sugar shooting up. So that also has to be educated properly to the proper way of correct. And you have to review the treatment, and either lifestyle has to be corrected or that the medication according to the lifestyle has to be. Second challenges usually what they encounter is weight gain. Insulin it is known as diabetes treatment paradox. So what happens, the insulin is an anabolic hormone, so the patient on insulin tend to gain weight. So every 3 kg of weight gain offsets the benefit of 1%, what we call as KGA1C paradox. So solution is prevent hypoglycemia, because it is seen that the patients who get frequent hypoglycemia, they tend to eat more and they gain weight more. And newer analogs like glargine or diglu, tresiba today, these kind of newer analogs are known to have a lesser weight gain compared to the traditional insulin. So the patient is, you don't want the patient to gain too much of weight can always go for the newer insulin. And lifestyle modifications like exercise and proper, and combining this drug with weight neutral and weight decreasing anti-diabetic medication. SGLT2 inhibitor with insulin, you can, as a combination, the so the overall weight is the remains. And other third challenge is hypersensitivity reactions. That is like it could be hypersensitive reaction could be immediate or delayed, and immediate hypersensitivity could be local or systemic. Immediate local reaction could be pruritic erythema or be at the injection site, and could be systemic side effects like generalized urticaria, pruritus, and so on. And very rarely, insulin can cause anaphylaxis also, but this anaphylaxis has only noted in the older insulins like porcine insulin or bovine insulin. The newer insulins, which is recombinant, highly purified insulin, or analogs, there is no report of anaphylaxis. Is for the older generation. This is one example of the patient where skin test was done. First one is normal saline in the top, there's hardly any reaction you can. Second is the control of histamine injection. You know that Lantus and other type of insulin been given is allergic to almost uh, hypersensitive to almost all other insulin. And this uh, slide is not so clear. We have in the JCM published which insulin has which additive also. The person can be hypersensitive to the insulin molecule itself or the co-formulation like protamine they can be allergic to, or the trazol or latex. So this chart will tell which insulin has which co-components which can be cause of the hyperinsulinemia, so that you can by using this chart you can pick and choose the alternative which doesn't have those molecules. And this is how we can do the rapid desensitization protocol for insulin. And many a times if the hypersensitivity cannot be managed at all, or the alternative insulin also is hypersensitive, then you have to choose non-insulin based therapy, maybe a GLP-1 analogs, or you can use methotrexate like immunosuppression. Sometimes monoclonal antibodies also you have to use. If it is very insulin is very essential for the body like type 1 diabetics, the pancreatic transplant, those patients can be used. So cost is another challenge in which regular insulin versus analogs, you can pick and choose based on the patient's availability, and you can reach out to certain companies like insulin manufacturer like Biocon or Novo and all. They have a for poor patients, type 1 patients, they can give free of cost insulin. And the costing, if a patient is very poor, they may not be able to store it properly also, that's another issue. They may not have a fridge in their house, you know. So this how the cost makes the challenges. And adherence is another difficult scenario where the patient can't be on insulin, like insulin dosing. If it is too frequent, many patients, because of their lifestyle, if a child, if you are giving where he has to go to school in the afternoon, he will skip the afternoon dosage, and anybody is doing night shift or some employment which can't permit their own time, they may miss the afternoon dose if you follow basal bolus. Probably in those times we have to compromise and go with the premix kind of insulin, suiting their one routine. And the injection techniques also very important. Many people don't change the insulin needle for many days. Pain will be there, so they won't because of the pain, persisting pain. They will not continue the insulin therapy. So you have to guide them how many maximum tricks with a single needle you can do, and you can consider alternative devices. If it's too painful with a syringe and vial, you can ask them for pen device and alternative molecules. And education is very important, like monitoring is very important, and the types of insulin you should educate them about the whether which is a fasting insulin, which is a postprandial insulin, and devices we told you in detail. So education about the devices is also important, and knowledge attitude towards insulin therapy. It is found that knowledge regarding the diabetes mellitus, almost 23% were adherent compared to the people with the poor knowledge. And similarly, knowledge about insulin injection technique, the good knowledge people had 21% adherence compared to the only 2.9%. And another problem with insulin therapy is social stigma. Uh, so many of the patients, when we ask them to go on insulin, your tablets are not working, they feel very guilty. They think that they have failed themselves in their managing the diabetes. So we should explain that it is nothing to feel guilty about it. Insulin is a usual medicine for diabetes over a period of time. And in type 1 patients, like you can have the support groups of type 1 so that they do not feel social stigma. And few slides I will tell about some special conditions. The factor affecting insulin are there, like site of injection, abdomen, leg, and arm. The rapidity of absorption is very different. Abdominal area, fastest absorption and slowest in the leg and buttock. So you have to pick and choose the type of insulin, prandial versus uh, fasting insulin according to this site, because site also matters. And uh, factors affecting the blood flow through the skin and fat, like smoking decreases the blood circulation, so decreases absorption. And exercise, hot bath, messaging the insulin site can increase the blood flow and absorption. That has to be consideration. So immediately after hot bath, you should avoid injection. And neonates and young children, problem is very small dose titration is required, and our insulin injector comes with only 1 unit titration. So what you have for that, you have to use specialized insulin pen, which comes with zero point 0.5 units titration. And teenage problem is whenever there is a puberty achieved, because of hormonal surge, they will be having insulin resistance. So sugar may go up, and type 1 they may land up in decay. That needs to be taken care. And pregnancy, we know it is high risk because of altered physiology. Targets are different. That needs to be taken care. And old age people, they will have decreasing cognitive and functional decline. So, and they're more susceptible for hyperglycemia due to comorbidities. So, much more individualization in these people as required. And last but not the least is the blind diabetics. So, they can't do their own glucometer checking, and very difficult to inject themselves. So,
Dr.
uh,
Praveen, can you
yeah,
wrap it up
this is the
now?
last slide. Uh, so, the insulin pen, the tactile and with audio is required, and blood glucose monitoring devices with audible and tactile feedback is also required. That is one which industry has to work with. Thank you very much.